variety of noises from the respiratory tract. You could have a stridor, which is a high-pitched inspiratory upper airway alarm, but the stridor could also be biphasic or expiratory. You could have a wheeze, which is generally polyphasic because you have different frequencies, and it is an expiratory musical sound suggesting to you that the airways are obstructed and are in distress. You could hear crackles, which are also called as creps, which could be because of fluid, it could be because of a collapse, infection, or it's telling you that the pathology is somewhere either in the alveolus or probably in the interstitium, where you could hear fine crackles of an interstitial lung disease. Now, if your child is grunting, you're in trouble because the child is trying to generate a self-beep to keep his lungs open. And if you have a silent chest and the child is too tired and sick looking, it is really a danger sign. So, I hope you can hear me. Now look at this. What do you think you can type chat box. Okay, so this is something called as a stridor, and this child had an inspiratory stridor. So if your obstruction is in the pharynx or just above the glottis, you will get an inspiratory stridor. If it is at the level of the glottis, you will get a biphasic stridor. And if it is below, that is somewhere in the trachea, below the vocal cords, you will tend to get an expiratory stridor. So by listening to the stridor, you know where the pathology is. But sometimes you hear noises like this. So now look at this. Okay, what can you hear? Right? What can you hear here? Anybody? You want to type in the chat box? Okay. So this is a child who is probably snoring, but therefore it tells you that the noise is coming somewhere from the nasopharynx. So the problem is somewhere in the nasopharynx. Sometimes you hear, apart from a snore, a noisy breathing which is sounding with as though there's a lot of secretions. So that could be a stutter or a snuffle. And here you know the area where the pathology is. But sometimes you will hear something like this. Is a P, which is coming straight from the chest. So based on where you're seeing what, you will know what the pathology is like. Okay, now let me jump to my first case. Now this is a 4-month-old who was weighing 3.5 kg. He was 3.5 kg at birth, and he presented to us with stridor at the age of 4 months, and at this point of time he was still weighing 4.5 kg. Okay, and the parents complained that his stridor increased when he was crying, when he was feeding, and it decreased in sleep. There was history of difficulty in feeding, and he almost choked while feeding. On examination, what I've just showed you, this kid had an inspiratory stridor. You can see the suprasternal indrawing, you can see the subcostal indrawing. When you have suprasternal, you're looking at the pathology higher up. Okay? When you have an intercostal indrawing, you're looking at the pathology probably in the lungs. So this is how the child came to us. So obviously this child had a noisy breathing, he had failure to thrive, he had difficulty in feeding, and a stridor which became worse on crying and feeding. So this kid, we did a scoping. So this was done with our team, with Dr. Anju and AZ at the SRCC. So what you can see here, is the epiglottis. Normally the epiglottis has to open up to allow the air to go into the airways through the vocal cords. But if the epiglottis is going to lie like this and collapsing it on the airway, the child will have to breathe with really great difficulty to open up the epiglottis so that the child can breathe. And that is resulting in his stridor. So this is nothing but a simple laryngomalacia. Why I took this case is because this is very, very common in practice. So you will have a child who will be well for the first 2 weeks of life, and suddenly after the 3rd, 4th week of life, he will start getting this kind of a noisy breathing, and the parents will call it cold and cough. And actually it is not cold and cough, it is an inspiratory stridor. So how do you know that this is inspiratory? So there are different types of laryngomalacia. Here the first one, where the arytenoids are going into the larynx. The second one here, if you look at this one, this is a type 2 laryngomalacia. Okay, here the epiglottis is omega shaped. Okay, and it is folding upon itself and causing the obstruction. Whereas the type 3 is the worst one, where everything is flopping in, like the one we just saw. Now, these are kids who will present with noisy breathing, and parents cannot decipher that this is not cold and cough. Parents will think it is cold and cough, and that's how they come to you. And how do you know that this is laryngomalacia, not cold and cough? One, the child will have no fever. Two, the stridor becomes worse when the child is active and crying. And if you put the child prone, the stridor suddenly disappears. And then if you auscultate the child, because if you auscultate the child up front, you will hear so much noise of conducted sound that you can really not make out whether it's coming from the chest or the upper airway. But if you put the child prone and then you auscultate this child, you will be able to hear a clear chest. And the parent will tell you when the child is active, the child has more noise, and when the child goes to sleep, or if you turn the child semi-prone or prone, his noise will disappear. So it's for you to decide that this is a laryngomalacia, not a respiratory infection. Most laryngomalacias are benign and they resolve by the age of 18 months. And by the time the child is 6 to 8 months, the child is already settling in. Some children require anti-reflux treatment because they breathe with so much of force that they cause reflux. So you need to give them anti-reflux treatment. Okay, and when do you intervene? We don't do a scopy in all children who have a stridor. We will do it when there is significant or progressive stridor over the age. We will do a scopy if the child has apnea or cyanotic episodes, or is failing to thrive, like this kid was. This kid was at the age of, he was almost just a kilo above his birth weight. Or if there are associated malformations, or when the diagnosis is in doubt, or if the stridor persists beyond the age of 18 months. Otherwise, the treatment is counseling the parents and maybe starting anti-reflux treatment. But sometimes when you think it's laryngomalacia and you do a scopy, you might see something else. So if you look here where my cursor is, you will see there is something reddish. Now this kid also came with persistent stridor, not growing weight. Okay, this child came to us from Gujarat. Now you see this red thing like a port wine stain. It is there through the airway. So it was a large hemangioma of the airway which was obstructing this child's respiratory tract. So this is a 6-month-old with inspiratory stridor since 3 weeks of life, failure to thrive. The treatment here is very simple. Once you diagnose it by doing a scopy, all you need to give is oral propranolol, and you may have to give it from 1 to 2 milligram per kg. And you need to watch for hypoglycemia if you use propranolol, and most kids settle down by 18 months of age, right? And so this is a very simple treatment if you diagnose this condition. Now, next case. This is a 6-year-old who was a full-term normal vaginal delivery. Birth weight was 2.8 kg. He had recurrent cold and cough with 2 episodes of acute otitis media, one occurring once in 15 days. So he's had 2 episodes, and it is occurring since the age of 1 year. Almost every other day he had multiple episodes. So 15-20 days he used to get one otitis media. He also had recurrent vomiting since the age of 1 year, and because of the vomiting, the parents took him to a gastroenterologist who diagnosed as reflux, and he was put on anti-reflux medicine. Because he had recurrent cold and cough, somebody also started him on inhalers. Okay, and he was on inhalers, anti-reflux medicine and everything of that, but he was not better. He also required frequent antibiotics. This is what the child looks like. Any of you who want to put in the chat box what do you think this child has? Okay, so the typical faces, I could not reveal the full identity of the child, but he had something called as open mouth breathing. He had a cross open bite, he had malocclusion, he had very enlarged tonsils and adenoids, and he had a nasal twang, which is all classical of adenoid faces. He had bilateral conducted sounds. So most of the time, he actually had only upper airway symptoms, and that was mistaken to be a lower airway symptom, and he was treated with inhalers and antibiotics. All his other systems were normal. We did a sleep study on him. We don't do sleep study on all children who have enlarged tonsils and adenoids, but this kid had multiple factors and he was sick for a very long time. So therefore we had to do a sleep study on him. One second, sorry. Yeah. And if you see, this is, W was awake. He was almost awake through the night. He barely slept. He barely got a REM sleep. And his AHI, that is the apnea-hypopnea index, was 30.3, which is considered to be a severe sleep apnea. His oxygen desaturation index was 27.2, and his minimum saturation in the sleep was 82. So this is a kid with obstructive sleep apnea. He was also a little obese due to tonsils, adenoids, malocclusion, and obesity. All right, so this is his hypnogram. So if you just look at these green lines here, they are suggesting apneic events, and if you look at the red lines below that, it suggests desaturation. So this is your baseline, and if you go below 100 here, that is desaturation whenever he has an apneic episode. He underwent a tonsil adenoid removal. So while we were doing a tonsil adenoid removal, we just quickly put in a scope to look at his upper airway, and this is called as DISE, which is called drug-induced sleep endoscopy. And you can see here, if you see from the sides, the two things which are collapsing and closing the airway are the two large tonsils that he had, very large tonsils that he had, which are almost collapsing the airway, causing him all the problems. Post tonsil adenoid, he was better. But children who undergo tonsil adenoid removal also, a good 15 to almost 30% can still have sleep apnea, so they need to be followed up. He was advised lifestyle changes for obesity, myofunctional therapy to train him to again start breathing from the nose and not the mouth, and a dental reference was taken for malocclusion. So I call it the missed entrance to the airway. So the upper airway is the forgotten part of the respiratory system, and I request all of you to actually have a peep at the upper airway before you look at the lower airway. And there has been an increased incidence of tonsil adenoidal hypertrophy post-COVID because of multiple recurrent infection that we are seeing in children these days because of variety of reasons, whether it was post-COVID, whether it's our air pollution, increasing allergies, and increasing irritants. So we are seeing much more tonsil adenoidal hypertrophy than we ever saw before. Now the next case is a 4-year-old with dry nocturnal cough, wheezing, breathlessness, no fever. He had 4 episodes in the past 4 months, subsides after some treatment that they took, and father had history of allergic rhinitis with episodic sneezing, and this child, whenever he ran or he laughed, he started coughing. Okay, on examination he had atopic dermatitis. He also had bilateral scattered wheeze, and his other systems were normal, right? He received theophylline, salbutamol, deflazacort, everything. He used to get better, but his symptoms used to come back. And he was nebulized with levosalbutamol and ipratropium combination multiple times. But his symptoms kept recurring, and therefore they came for a second opinion because the child kept on falling sick. So how would you approach this kind of a patient? What will you ask? What questions will you ask? If you want to put it in the chat box, it will be a good idea. Okay, what questions would you ask? So I would call it the 10 commandments, right? Okay, you can test yourself by putting it in the chat box. So what questions you're going to ask? You will ask for onset of cough, whether it was acute, subacute, sudden. You will ask for the type of cough, wet or dry. You'll ask for the timing of the cough, daytime or nocturnal. You will ask for frequency of cough, whether accompanied with wheezing, whether persistent or intermittent or variable. You'll ask for triggers, viral infection, seasonal activity, any trigger like smoke or air pollution, etc. You will ask for how long it takes to settle down, whether the child needed to be hospitalized. You'll ask for how the child is in between these episodes of cough, whether the child is well between it. And then you would look for weight gain. You will look for personal atopy, family history, and whether he responds to any particular treatment, especially bronchodilators or corticosteroids. So answer to this question will help you come to a diagnosis. It will also help you to look whether there is asthma or a probability of asthma. So if you have a typical child who's got wet cough starting very early in life, you're sure this is not asthma. If you have a child who's not gaining weight, you're sure it is not asthma. If he's unwell in the interval period, it is not asthma. If it is onset of cough very sudden, then it is not likely to be asthma. So simple things like this will tell you where you are heading. So this child had multiple triggers. There was family history of allergy in the father. This child had atopy. So the diagnosis was probably a high probability of asthma. So would you investigate this child? Do we need to really investigate children who have asthma? The answer is here in this slide. CBC may show you eosinophilia, but it doesn't help you change your treatment unless you are a very severe asthmatic and you're looking at biologicals for treatment. X-ray chest is done mainly to rule out other causes rather than to diagnose asthma. Spirometry, if your child is above 5 to 6 years of age, yes, GINA guidelines mention that we need to do spirometry in all children. Allergy testing only and only if it is recurrent and non-responsive to therapy. Pheno, not available freely, is just a marker of the eosinophilic airway. Impulse oscillometry in a few selected cases and especially in younger children. And this is the standard GINA guidelines which will help you decide the severity of his asthma, and based on that whether he's in step 1, 2, 3 or 4 you would like to start treatment. So this kid was getting almost every month. Probably I'll put him in step 2 and he probably would benefit with daily inhaled corticosteroids as a prophylactic or a preventive treatment. Now when you have a child who is wheezing, I would like to classify them into 4 categories. First one is first episode of wheezing. It could be like any viral infection like a bronchiolitis. Episodic wheezer is recurrent viral. Suppose they go to play school and they start getting cold and cough again and again, you will think of an episodic wheezer. This kid, a multi-trigger wheezer, multiple triggers which cause him to wheeze with a family history, very likely to be asthma. But you have a category which is called the atypical wheezer, and you would think of it especially in younger children. So these are kids with persistent symptoms, neonatal or early onset of symptoms, failure to thrive, history of choking, regurgitation of feeding difficulties, bacterial, they have multiple bacterial infections or multisystemic infection, multisystemic involvement, localized sign, clubbing. When you have this is the category you need to investigate. Okay. Now, 9-month-old, history of recurrent wheezing since the age of 6 months, progressive breathlessness over the last 5 days. Okay, low grade fever, no feeding difficulty, no diarrhea, other infections like otitis media, pyoderma, no history suggestive of foreign body aspiration, no family history of coughs, asthma, atopy. So this is a 9-month-old who's wheezing recurrently since the age of 6 months, and now he's getting progressively worse, right? And you should also ask for birth history. Suppose you had a child who was preterm, who was in the NICU, who needed to be ventilated. You could have chronic lung disease of infancy, especially if these kids have a bronchopulmonary dysplasia. But this kid was well, he had no perinatal events. So on examination, he was weighing 7.5 kg, his height was 68, so he was in the 25th centile. He was not that bad as in weight-wise. He had marked distress. He had come with a respiratory rate of 90. He had bilateral wheeze, no fever, and he was desaturating on room air. And his other systems were normal. So this was causing us a little bit of a red alert because he was desaturating and he had marked respiratory distress and he was progressively getting more breathless. This was his X-ray. We looked at his X-ray, there was bilateral air trapping, but there was really nothing else that we could appreciate on this X-ray. We thought maybe it's some of these bad viruses which is causing him. So he was treated with oxygen. He came in the monsoon months, I remember. He was nebulized, he was given steroids. We also gave him foamoxiclav. We gave him oseltamivir, supportive treatment. He improved and was discharged. He was discharged after a week stay in the hospital. On follow-up, after 1 week of discharge, he was still wheezing and tachypneic. At this point of time, we thought let's give him a trial of inhaled corticosteroids. But a 1-month follow-up showed that he had persistent wheeze. So therefore, this was a kid now who has persistent wheeze with poor response to bronchodilators and inhaled corticosteroids. So if you remember my last box, atypical wheezer, poor response and persistent wheeze. So asthma by definition is recurrent wheeze. This was something called as a persistent wheeze. Okay, so this kid now needs to be investigated, right? Sorry. And so we definitely decided to do some investigation. So we did a blood count. We thought we should rule out TB in our country. We thought we'll plan a CT, bronchoscopy. Immunodeficiency workup was in our thought, but a little lower down because he's a well-grown child, no multisystemic infection. We thought we should rule out mucociliary disorders. PCD, and probably do a whole exome sequencing for a genetic workup. So the first thing we did was we did a CT on him. So if you look at his CT, so this here is the trachea, and we saw a large mass here which is almost compressing the trachea. If you can see this large mass which is compressing the trachea. If you see it here also, you can see the large mass. This is your trachea, and this whole large mass is compressing. You can see it very nicely here. Large mass compressing the trachea. Okay, so here was the clue that this was the reason why he was continuously wheezing. Right, these are images which are restructured and made. So you can see this like a cutout lesion on the trachea. That was the mass which was compressing the trachea, right? And this was nothing else but a bronchogenic cyst, which is a congenital birth defect, and this cyst can obstruct the airway and can even actually be life-threatening. So bronchogenic cysts occur due to an abnormal ventral budding from the tracheobronchial tree. They can be in the mediastinum, they can be inside the lungs, they can be subdiaphragmatic, retroperitoneal. They get present in the newborn period with respiratory distress, cyanosis and feeding difficulties, or they can come in the second decade of life and they can actually mimic asthma or pneumonia, and sometimes you may incidentally pick them up on a chest radiograph. The red flags in our patient was early onset, persistent wheeze, and a partial response to bronchodilators. So this should make you think that this is not asthma but something else. Next case, a 7-month-old, one of the twins, 2.4 kg at birth, born of a C-section, uneventful neonatal period, breastfed plus top-fed, came with history of vomiting and irritability since the first month of life. Actually, they went to the doctor in a local facility in the suburbs for vomiting and irritability. When they went to the doctor there, the doctor found the child to be tachypneic. And on examination of the chest, his air entry was bilaterally equal, he had no foreign sounds. An X-ray was done for his tachypnea, and they found that there were patches and cough consolidation more on the right side but minimal on the left side as well. You can see the airway and all is perfectly fine, but there was these consolidations which were seen on the right upper lobe, middle lobe, on the X-ray. So he was diagnosed to be having a pneumonia, okay, and he was admitted. He was started on ceftriaxone, but there was no improvement in 5 days. He continued to be tachypneic, and therefore a CT was done. So the CT also showed right upper, middle lobe, there was lot of these consolidations. Rest of the lung looked okay. There was minimal consolidation even on the left upper lobes. So because he was not better, he was transferred to a higher center. Okay, there a bronchoscopy was done. Bronchoscopy showed Klebsiella rhinovirus. He was treated with antibiotics. Repeat X-ray this was after 1 week. It almost showed no improvement. Okay, he was treated. His tachypnea was slightly better. He went home on request, but he quickly to come back, where again he was breathless, and this time he had fever, cough, breathlessness, required NIV support. Antibiotics had to be restarted, and was kept in the hospital till he got better. The third time when they did the X-ray looked the same, child's tachypnea was the same, and this is the time we first saw the child. So we thought let's revisit the history. There was no fever, no choking, vomiting and irritability was there initially, which had now settled. Other twin was normal, no cox contact, no feeding difficulty. He was well grown, 6.1 kg, no other findings, mild eczema, but beyond that there was absolutely nothing. So we were a little wondering what could this be. Looking at the persistence of the patch, we thought, is there something which is happening recurrently? So is there like a chronic aspiration, or is there a structural defect like a TO fistula, laryngeal cleft which is causing him to aspirate? Is there a cow's milk protein allergy? Is there something immunodeficiency or a mucociliary? We put it lower down because the child was otherwise well and thriving well, and there were no other features. So this was how our thought process went for this child, because this child had persistent symptoms and he had not improved in so many months of treatment. So what we planned to do a bronchoscopy to look for any reason for aspiration like a TO fistula, a laryngeal cleft, but that bronchoscopy turned out to be normal. We also did a specific IG against cow's milk protein, which is negative. Immunodeficiency workup, as expected, came normal. And now we went back to the drawing board. We asked for the grandmother history of oil installation in the nose, and the grandmother was continuously putting oil in this child's nose for the first 3 months of his life. So this was nothing but an exogenous lipoid pneumonia. This is a disorder which is very common, and it's a very common concept to put oil in the nose, and it's caused by inhalation or aspiration of mineral or plant based or animal based oil. And how do you suspect it? If you have a history of oil administration and it correlates with your clinical features at the time of your diagnosis, and if there is presence of persistent or recurrent unexplained pneumonia with or without hypoxia or tachypnea, radiological evidence of diffuse persistent alveolar infiltrates, and if you do a cytohistological study on a bowel fluid or on lung biopsy, you can actually see the lipid deposits inside the alveolar macrophages. This is a large study. From 44 studies were included, 489 participants from day 1 to 17 years of age from 13 countries of the world. So why I showed this study is that it is not only specific to India. So there are a lot of countries in the world where it is customary to put oil in the nose of the children. And here they highlighted that the diagnostic certainty was highest if the exogenous lipoid pneumonia was confirmed by doing a bronchoalveolar lavage and you do a frozen lung biopsy, or you document macrophages with lipoid, with the lipid content. Okay, so you can do something called as lipid laden macrophages on bowel, stain for them and identify them, and then you could confirm the diagnosis. And treatment consists of course stopping oil installation, supportive therapy, antibiotics when there is secondary infection. Corticosteroids are the crux of the treatment, the mainstay of treatment. And some of these children who tend to have a lot of tachypnea, one can do a whole therapeutic whole lung lavage. Okay. So this is what a whole lung lavage, you can see actually milky fluid coming out, and this is how, if you stain, you will see this is oil red O stain, which can give you the presence of lipid inside the macrophages. And this is how the CT will look. Looks like diffuse, multiple consolidation bilaterally in both the lungs. I already highlighted the treatment: antibiotics, oxygen, some may require ventilation. Corticosteroids may have to be given for a long period of time, from 2 weeks to almost 14 months. Some studies on inhaled corticosteroids are also there, and therapeutic or partial whole lung lavage and prevention and early diagnosis. Now look at this girl. What is she doing?
Why do you do this, Vinaya?
Because sometimes my
Why do you do this, Vinaya?
Because sometimes my fingers feel uncomfortable and I feel like my bones have to crack or something. That's why.
It doesn't pain, no?
No, it doesn't pain anything.
Okay, so anybody, I don't know if you know this is an entity called as restless leg syndrome, or okay, and this is a motor sensory disorder with uncomfortable sensation which occurs in the lower extremity, but it can also occur in the hand. And the child feels the need to keep moving because it comes not of pain but some kind of a creepy sensation. Typically it will occur more in the time the child is going to bed in the night. Periodic leg movement disorder is a similar disorder, but that is a diagnosis which is done on sleep studies, because these are repetitive movements, stereotypic limb jerky movements in sleep, which are picked up only on a sleep study. The pathophysiology for both of them is common because there is an underlying dopaminergic dysfunction because of iron deficiency. So restless leg syndrome, you will have many children who will come and say this to you. So therefore I thought I should include this case. Urge to move legs, okay, usually accompanied by uncomfortable or unpleasant sensation. Mostly occurs in the lower limbs but legs, but can also occur in arms. It is induced by rest, and it begins to worsen during the periods of inactivity, gets better with activity, and it is worse in the evening and night. Okay, so this mnemonic urge is easy to remember. And periodic leg movement, as I told you, can be diagnosed only on a PSG or a sleep study. They are both caused by low iron. So if you do a serum ferritin level, if your ferritin is less than 50 nanograms per ml, with these symptoms, you would think of restless leg syndrome. And iron is required for synthesis of dopamine. Deficiency of iron causes dopaminergic dysfunction and causes the sensory component disturbance. The treatment is giving iron and are advising non-pharmacological treatment like moderate exercise before bedtime, applying a hot or a cold pack. But we need to avoid caffeine and antihistaminics because it interferes in the dopaminergic pathway. In adults, sometimes gabapentin, benzodiazepine, etc. is used, but in children, we generally only use iron and non-pharmacological treatment. Sometimes you may have to differentiate restless leg syndrome from growing pains. So restless leg occurs in onset of sleep, and even growing pains occur at that time. Presence of restless leg prevents sleep onset, but in growing pain, the child goes to sleep and wakes up from sleep, telling that the legs are having some pain. Here it is an uneasy feeling of discomfort in RLS, but in growing pains, there is bilateral pain in the thighs and the calves and the popliteal fossa. Ferritin levels are low. In growing pains, sometimes you may have low vitamin D and laxity of joints. Diagnosis of RLS is clinical, and so is growing pains a clinical diagnosis. Treatment for RLS is iron or gabapentin, non-pharmacological methods. Whereas for growing pains, you will do massage, heat, give an analgesics and vitamin D if that is deficient. This is another case. I think I have just enough time to finish this case and we will stop here. Okay, 10-year-old female child came with wet cough and decreased oral intake since 10 days. Okay, sorry. And she had just this cough, fever since 10 days, and she was failing to thrive. She had a weight of 22.5 kg, height of 133 centimeters, below the third centile. She was afebrile, normal heart rate. She was slightly tachypneic with mild intercostal, subcostal, and supraclavicular in drawings. She had saturation of 92% on room air. She was clubbed. She had mild pallor. She had decreased air entry on the left side with scattered Krebs bilaterally. So she came with some lower respiratory pathology with clubbing. That's how she came. And this time when she came to us, she had a history of 10 days. When we went into her past history, at the age of 3.5 years, she had developed cough, fever, and she had some weight loss and loss of appetite. She was admitted for the same, treated as a left-sided pneumonia, and was also empirically started on AKT as her symptoms did not improve. At 4 years, her cough still persisted. She had received all the AKT, multiple antibiotics in between, but her cough was still there. At 6 years, somebody did a CT on her, which showed destruction of the left lower lobe with hyperinflation of the left lung. And she was started on inhalers for that. Localized sign, starting on inhalers, one needs to question mark. And before she came to us, she had admitted multiple times. She was diagnosed as necrotizing pneumonia, multiple courses of antibiotics, CT suggestive of left lower lobe consolidation, and then actually the child was referred to us for a bronchoscopy. These were the x-rays of the old x-rays of the child. So if you see here, the left lung is totally hyperinflated. And if you look behind the heart, you can see a straight line here. This is suggestive of a left lower lobe collapse. You can see it even on this x-ray. This is almost kind of 6 months later. You can see a collapse here, and the left lung is definitely hyperinflated. Okay, so we kept, because it was a localized problem, we thought that this child probably has a forgotten foreign body. But the history was going back to 7 years. She has come to us at the age of 10 years. And this history is going from the age of 3.5 years. The other differential we thought was whether there's a congenital lung malformation like a sequestration. So a CTPA was done, and the CTPA ruled out a sequestration. We also thought whether this is some kind of a resistant pulmonary TB, drug resistant, but but TB won't last so long. From age 3.5 years to now, if she had an MDR TB, she would not be like this. We thought whether it's something like an infection and a post-infectious bronchiectasis was our other thought. Mucociliary disorder was less likely as it was very localized. So this was the CT which she came with to us with, and if you see here, okay, you see this left lower lobe of the lung which is totally destroyed. You can see there's a lot of kind of cystic spaces which is suggestive of bronchiectasis, okay, and there's a complete collapse of the left lower lobe, and here you can see that this is compensatedly hyperinflated. The left upper lobe is showing a compensatory hyperinflation. Okay, and if you can see this in this view as well. Almost the whole of the left lung seems to be destroyed. It is complete, showing consolidation with some cystic spaces and minimal hyperinflation on top. We did a bronchoscopy on her. Mind you, the symptoms are from the age of 3.5 years. This is the bronchoscopy was seeing. So we went in. This was done just about 10 days back. This child came to us. So we have entered the trachea. You can see the cartilage, C-shaped cartilage of the trachea. This is the right, this is the left. We entered the left first because the pathology is in the left. As soon as we entered the left, we could see a lot of pussy secretions coming out. But soon we started seeing something greenish there. You can see here. So this was a forgotten foreign body. What I want to tell you is that if you have a child with persistent collapse, any age, please do not think of, please think of a forgotten foreign body. This child's lung would have been saved if this foreign body would have been diagnosed at the age of 3.5 years. Back to her, I had another child who came to me with a foreign body for sitting for 2 months, and I'm sure that child's lungs are now intact and safe. This is what we removed. It was some cap of a pen which was lying intact into her lungs for the last 7 years but had destroyed her complete lung. So my key takeaways from today's clinical cases are sound before imaging, in the sense your stethoscope and what you hear from the patient will help you diagnose 80% of cases, even in this world of AI today. Every sound is an address, so find out from where the problem is coming, what is the anatomy behind it. If you have a silent chest, it's a red flag. It means exhaustion, not recovery. Age shapes the diagnosis. So depending on the age of the child, you can also think what is the likely diagnosis. Know when to refer. If you have a child who's clubbed, who's failing to thrive, who has a low saturation, who has stridor at rest, who's tachycardic or tachypneic out of proportion, this is a kid you need to refer quickly. Or you have somebody with persistent symptoms and the child is not improving. You need to treat the child, not the X-ray. The child with the lipoid pneumonia, you need to go in depth and treat the child, not the X-ray. The parent never came to you for a pneumonia at all. So, and on the other hand, a clear film also does not rule out a serious condition like the child with bronchogenic cyst. So here, localize, come to a diagnosis, act before it silences everything. Thank you so much. Any questions would you like, I would take after this, and then maybe we can go on to the next presentation. Anything in the chat box, Tanvi? If there's something in the chat box, you could read it out for me. I don't see anything there.
No question, ma'am.
Okay. So I'll go to my next question, next presentation. Sorry. Is my slide visible?
Yes.
Okay. So I'm going to talk to you about antibiotics and the use of it in the respiratory tract. Okay. So why are we worried about antibiotics? One is, first of all, there are hardly any new antibiotics in the pipeline. And antibiotic resistance is declared by WHO as one of the world's top 10 global public health threats. You and me would get into the ICU and could get the most fanciest of procedures done. But what would be worrying us, or what could actually be a problem, could be an infection which could kill us in the ICU, a resistant bug. And it is a growing threat with very, very high mortality. Antimicrobial resistance is expected to cause 5.2 million deaths in the Western Pacific by 2030. And it is not that India is far behind, and probably India is more further ahead. The burden of respiratory infections, is the another reason why antibiotics are misused. So we have a huge amount of respiratory tract infections, some of which require antibiotics, and some which actually do not require antibiotics. And sometimes the differentiation between a viral and bacterial infection may be so difficult, hence it lands up with an antibiotic misuse. So we therefore need an antimicrobial stewardship in the pediatric respiratory tract infection area, because this is the most common problem in the pediatric age group, where the commonest reason why a parent would bring his or her child to the OPD is respiratory tract infection. And it's also the most common cause of hospitalization, also responsible for under 5 mortality. Distinction between viral and bacterial etiology is neither easy clinically nor by investigations. But with increasing vaccines, most infections are now are viral in origin. The Perth study, which was done across many countries, in about 9 countries across the world, showed that there is increasing incidence of viral causes of pneumonia rather than bacterial. And irrational prescribing of antibiotic may lead to antimicrobial resistance. So I'm going to quickly cover common cold, rhinosinusitis, sinusitis, pharyngitis, croup, otitis media, PBP, bronchiolitis, and pneumonia, and the role of antibiotics in these conditions. So basically, I'm going to cover antibiotics in childhood respiratory tract infection. Early accurate diagnosis, specific treatment, managing of comorbidities, and prevention are also the key in managing these conditions. 1-year-old female child who came with runny nose since 3 to 4 days, initially clear fluid but now yellowish in color. Dry cough since 2 days and fever up to 100 degrees since 1 day. So on examination, she was vitally stable, she was running around in your cabin, currently afebrile, chest was clear. What do you think this child has? So most probably this is viral. So neither the color of the nasal discharge nor the consistency tells you whether it's viral or bacterial. So in every viral infection, the first time, as the infection comes in, initially the discharge is watery, then becomes thick yellowish, and then towards the end becomes watery again before it disappears. So neither the yellow or the green color tells you whether this is viral or bacterial. And just because the discharge is yellowish, don't go ahead to start an antibiotic. Okay, so rhinitis, rhinosinusitis, multiple number of viruses are there which can cause it, and the list is ever increasing. And children do get 6 to 8 episodes of viral URTI every year as per WHO, and in some it could be up to 12 a year, and there is no role of antibiotics. But sometimes we get these children who have little runny nose, complaints of throat pain, cough, okay, and if you examine the throat, it looks red. So what your notes will say, congestion present or throat mildly congested, but there's also rhinorrhea. Do you think this warrants an antibiotic? Again, here the answer is no, because this could simply be a viral respiratory, upper respiratory infection, a viral pharyngitis. How do you differentiate? You need to differentiate Viral from the streptococcal throat. In streptococcal throat, the onset is generally more acute, the throat is more red, you may have petechial hemorrhages in the palate. These children may have high fever, headache, nausea, vomiting, abdominal pain. You may have tender lymph nodes. You may have pus-filled exudates on the tonsils. This age group is typically between 5 and 15. Presentation is more in winter and early spring, and there may be history of contact. You may have sometimes a scarlet fever like presentation with a rash, which is kind of a rough rash, like a sandpaper rash on the body, and peeling of the skin, and even we sometimes even children have nails which kind of come off, and that could be also a hallmark of streptococcal infection. Viruses generally are multisystemic. So you may have conjunctivitis, skin rash, coryza, hoarseness, diarrhea. You may have all the possible symptoms, and and you may have a rash like measles or many other rashes which could be there, and that would tell you that this is most likely to be viral. Mostly when you have a viral infection, you do not have tender lymphadenopathy, and these are kids who are generally well. They are well between symptoms of yeah. Just hello, yeah, Tanvi, you called. Huh. So you will have children who are well between episodes. They are well actually. They are going around. They are playing. They're good. Okay. Sometimes, but what confuses you, you may get confused because you may have you may have EB virus, which will come similarly, like a group A, like a strep throat, because you may have these patchy exudates. But EB virus has certain hallmark features which helps you differentiate from a group A beta hemolytic streptococcus. What you will get in a EB viral infection is you will get lymphocytosis on CBC if you do. You may get lymph nodes which are large but may not be so tender. These are children who tend to have large adenoids as well. They may get inflamed, enlarged during the infection, and you may have snoring. You may have a hepatosplenomegaly. CBC may also show thrombocytopenia. And if you do an EB virus slide agglutination test, which is the EB virus viral capsid antigen IgM, which will be positive. So this will help you differentiate between a bacterial etiology and a Epstein-Barr viral etiology. The Centaur, modified Centaur scoring can be used, but of course, it is good to rule out rather than rule in. So if you have absence of cough, swollen tenders, anterior cervical lymph nodes, fever, and tonsillar exudates, and your age is more than 3 years, okay, then you are likely to think of a bacterial throat infection, right, rather than not, right? So this is the sensitivity may not be high, but as I told you, a positive Centaur score may not rule in, but a negative definitely rules out. Okay, we need to treat a group A beta hemolytic strep throat, because though the strep throat will resolve even if untreated, but you need to treat it to prevent complications like acute rheumatic fever and local infective suppurative complications like peritonsillar abscess and cervical adenitis. This is the standard chart of doses and of the drugs that you will use. Okay, so penicillin, of course, now no longer available and not really used, was the first drug of choice. Otherwise, you can use amoxicillin in the dose of 50 milligram per kg in two divided doses for at least 10 days. The treatment is for 10 days. And those who are allergic to penicillin, you can use oral cephalosporins like cefadroxil, cephalexin, clindamycin, or even azithromycin. 8-year-old, runny nose, cough since 5 to 6 days, nasal discharge is thick and yellowish, headache especially around his eyes, fever for 3 days, which has now become less. And when you examine him, there's tenderness over the forehead, cheek, and there's purulent nasal discharge. So after the 6th day, he's got purulent discharge, there's headache, saturation is good, chest is clear. What do you think this child has? So sinusitis is a clinical diagnosis. You really don't need a CT or an X-ray to diagnose sinusitis. Most commonly, it follows a viral rhinosinusitis, and you may start off with a viral and then you can get into a bacterial pathology, or you could have bacteria like Streptococcus pneumoniae, H. influenzae, Moraxella, and rarely staph. Only chronic sinusitis is polymicrobial, but you must remember that in the respiratory tract, these are the three common bugs which cause all the problem. And of course, staph is important for sinusitis and also staphylococcal pneumonias. So approximately 50% of H. influenza and 100% of M. catarrhalis are beta-lactamase positive, meaning thereby they will not respond to your plain amoxicillin, and they need a beta-lactam inhibitor like in the form of sulbactam for it to work. Okay. So this is your sinuses. If you see, you have frontal sinuses, sphenoid sinuses, ethmoid, and maxillary. So you have all of them in pairs, and they have an age at which they develop. All right. So ethmoid and maxillary. I remember me is present at birth. That is maxillary and ethmoid are present at birth. Okay, but the pneumatization continues up to age 3 to 4, especially for the maxillary sinuses. So you can get sinusitis at birth also, because the ethmoidal sinuses are pneumatized at birth. The sphenoidal sinuses appear by age 5 years. So you cannot get sphenoidal sinusitis at birth or even in children below age 5. The frontal sinuses appear around 7 to 8 years, and they get fully developed by the age of 14 years. So when will you suspect sinusitis? If you have persistent symptoms of rhinitis for longer than 10 days without. So if you have a viral rhinitis, over a period of 7 days the symptoms starts improving. But if the symptoms persist or they are worsening after a week's time, then you will think of sinusitis. Or you may have a very severe acute onset with purulent nasal discharge, severe headache, swelling of the eyelids and the eye, and that could also be a sinusitis. You can also have sudden worsening or new symptom known as a two-phase illness or a double sickening after initial improvement, which is also well described in sinusitis. In sinusitis, you definitely need to use antibiotics. So the initial empirical antibiotics are amoxiclavulinic acid in the dose of 40 mg per kg. Or if you're suspecting Moraxella or non-typable Hib, which is resistant, then you may have to use either a high dose, if you're suspecting Streptococcus pneumoniae with resistance, then you may have to use amoxicillin in higher doses. In India, we generally prefer to use amoxiclavulinic acid for those when we are suspecting Hib or Moraxella catarrhalis, where you need a beta-lactam inhibitor along with amoxicillin. So for resistant strep pneumonia, you need higher dose amoxicillin, but for a beta-lactam inhibitor addition is required for HIB or Moraxella. If you have a penicillin allergy, you can use cefodoxime or levofloxacin in older kids. Prefer not to use levofloxacin because it's a reserved drug for MDR-TB. So we would use a cefodoxime if penicillin allergy. If there is severe infection, poor response to oral, then one may have to use IV ceftriaxone and IV ceftriaxone, then switch to oral antibiotics when the patient is better. But if there are complications, an ENT reference and further management may be required. And the complications could be in the form of orbital, periorbital cellulitis, meningitis, brain abscess, subdural empyema, osteomyelitis, etc. Azithromycin and trimethoprim sulfamethoxazole should not be used to treat sinusitis in view of high prevalence of antimicrobial resistance. Now this is a 1-year-old, runny nose, fever since 1 day, and was irritable, rubbing her ear and cries when anybody touched her ear. Otoscopy, you must all have an otoscope in your clinic. If you don't have, you must buy one today. And if you look at the eardrum, you see this bulging eardrum which is red, inflamed. It's lost its pearly white look, and this is classical for acute otitis media. Most common pathogens for otitis media are Streptococcus pneumoniae or H. influenza and Moraxella. Okay, and if you have H influenza, otitis media, you may have associated conjunctivitis. Okay, and it can also occur as a complication of bronchiolitis. Your otitis media is known to occur along with bronchiolitis. Few viruses either alone or with superadded bacterial infection like rhino, adeno, influenza can also cause otitis media. And if you do not treat it properly, you can have complications like chronic suppurative otitis media, mastoiditis, or an intracranial complication including meningitis. So this is a flowchart. I think you just take a picture. If you have a child who's less than 6 months, you should treat immediately. Start antibiotics even with a presumed episode of airway. So in office practice, otitis media becomes one of the most common areas where antibiotics are misused. If you are between 6 months to 2 years, again you need to treat immediately. Especially if it is bilateral, you definitely need to start antibiotics. If it is confirmed unilateral of any severity also, some of the guidelines would have reduced the age cutoff, but by and large, between 6 months and 2 years, you would also like to treat with antibiotics. In children above the age of 2 years, you need not use antibiotics upfront. Only if it is severe, with severe pain, bilateral, very high grade fever is the only time you would start antibiotics. Otherwise, you will wait and watch with supportive care and painkillers. And you should watch these children for 2 to 3 days before upfront starting the antibiotics. So the decision factors to start antibiotics is age, severity, whether it's unilateral or bilateral, and also compliance to treatment. So if you have a patient who's uneducated or you think may not follow up, maybe you bend rules and start him on an antibiotic. The dose of amoxicillin that we use to treat children with otitis media is 40 to 50 milligrams per kg. What is important is for younger kids, you need to give it for 10 days. In children above the age of 5 years, 5 to 7 days is more than enough. If you are suspecting beta-lactamase producing H. influenza and M. catarrhalis, then you need to give amoxiclavulinic acid. If you are suspecting strep pneumonia, you can give higher dose of 90 milligram per kg of amoxicillin. If you have given amoxicillin and the child has not responded within say 48 to 72 hours, then you may move to amoxiclavulinic acid. So this is how you would treat children with otitis media. You need to follow them up. Some children with otitis media, you need to follow them up. Post 3 months, some of them may have OME, you may need to do a tympanometry. A 3-year-old, fever, runny since 2 days, barking cough, exacerbated on running, crying, active, playful in the interfebrile period. He had an inspiratory stridor with mild rhinitis. So what is this? This is nothing else but a croup. So you need to look at, you need to differentiate certain things when you have a child with a barking cough and an inspiratory stridor. We need to understand whether the pathology is supraglottic or infraglottic. If you have a supraglottic pathology, you will have drooling of saliva, soft stridor and toxicity. And the differentials here are peritonsillar abscesses, diphtheria, foreign body, retropharyngeal abscess and epiglottitis, which we don't see really very common in our country. But if you have an infraglottic pathology, you will have a barking cough, significant stridor. Here the differentials are croup, that is your laryngotracheobronchitis, diphtheria, foreign body or a bacterial tracheitis, which is again less common. Of these, retropharyngeal abscess, bacterial tracheitis and epiglottitis are bacterial in origin, and the same bugs, H. influenzae, strep pneumonia, moraxella, rarely staph, are responsible, and these are conditions where you need to start antibiotics ASAP. But croup is generally viral in etiology. Onset is gradual, child looks well but has a horrible barking cough, harsh stridor, worse at night. This is how a child with croup will present. It is caused by parainfluenza viruses. Type 1 and type 3 account for more than 75% of the viral laryngotracheobronchitis. But there are other viruses which can also cause it, like influenza, adeno, RSV, measles, metapneumonia, etc. Okay, you should not do an X-ray chest, X-ray neck, which is really not required to diagnose it. And antibiotics are not indicated in croup. How do you treat? You classify the severity from mild, moderate to severe to impending failure. In mild, And you also look at clinical features like stridor, retractions, air entry, cyanosis, and consciousness. Based on that, you can score and you can decide whether the severity is mild or very impending failure. If it's mild, then you can give oral steroids and send them home. If it is moderate to severe, you need to give nebulized adrenaline with steroids. If you cannot trust the patient, please start the steroids and admit the patient. Okay, so you can take a picture of this. This is how you treat. Okay, what your group. For moderate and severe, hydration is important, antibiotics are important, oxygen only if moderate to severe, dexamethasone in all cat, and you can use any steroid. All steroids work, oral works, parenteral works, inhaled works. Alright. Salbutamol generally not required, adrenaline for moderate to severe category, antibiotics not required, lansoprazole not required. 4-year-old, fever 7 days, wet cough since a month. No other history, no TB, weight loss, nothing. Hemodynamically stable, saturation of 96% on Ruben, no clubbing, cyanosis, pallor, nothing. Occasional bilateral scattered clips. So he's just been coughing since a 1 month and now he's got a wet cough and he's got mild fever, otherwise he's well. So what will you diagnose here? This is a condition called as PBB or protracted bacterial bronchitis, alright? And PBB you suspect if you have cough which is wet and which is more than 4 weeks and all other causes have been ruled out. It is generally, fever is mild, child is thriving well, and the same bugs which I mentioned earlier are responsible for PBB. This is a condition where you need to give prolonged antibiotics for a minimum period of 2 weeks and up to 4 weeks. For you to pen your antibiotics for 2 to 4 weeks, you should be sure that this is a cough which is persistent for 4 weeks and is wet in nature and not recurrent cough. Okay, if there is no response, then this child needs investigations like a bronchoscopy, BAL, or one may need to look at other reasons for persistent wet cough. 9-month-old female child, bouts of dry cough since 15 days, which increased on crying, fever since 2 days, fast breathing since 1 day, unimmunized. So dry cough, 15 days, fever, and now tachypnic. On examination, the child was sick looking, had paroxysmal cough followed by desaturation. Okay, this is a classical cough you cannot miss, a cough with a whoop, that is a pertussis. Drug of choice are macrolides. Azithromycin is preferred across all age groups. You need to give it even to the household contacts and close contacts, especially if you pick them up early within first 7 days of illness to prevent spread of infection. The key here is absence of immunization, or sometimes you may have a senior citizen at home who's coughing because immunity to pertussis wanes over time, and you can have a senior citizen who may develop pertussis and pass it on to a younger child at home. 10-month-old, cold cough since 5 days, fever since 1 day, fast breathing, decreased feeding. On examination, otherwise a well child, saturation 93% and bilateral wheeze with respiratory distress. So 10-month-old, first episode of wheezy lungs with tachypnea. So your diagnosis is clear, it is bronchiolitis. There is no role of antibiotics for bronchiolitis, but you need to assess this child based on their feeding ability, presence of respiratory distress and saturation. If they are feeding well, happy with not significant respiratory distress, these kids can be managed on an OPD basis, but if they have any of these three, they should be admitted. If they are high risk, as in preterm births, congenital heart disease, or parents who may not follow up, etc., these are kids who need to be maybe need to be admitted and hospitalized and further managed. So no role of anything, only love and fresh air, hydration, oxygen if required, and no role of steroids, no role of antibiotics. Hypertonic saline can be used, but that is used only if the child has got severe bronchiolitis, which helps to reduce the edema of the airways. Adrenaline nebs have some role, and bronchodilators only if there is response to the treatment with bronchodilation, it can be continued. 4-year-old, high grade fever since 4 days, fast breathing since 2 days, abdominal pain since 2 days. So fast breathing, high grade fever with abdominal pain. Typically, if you have abdominal pain, this is a referred pain in these children, and it's a hallmark of a pleural irritation causing abdominal pain, which can occur in a lobar pneumonia. This child is also sick looking, poor intake, high grade fever, saturation 92%, tachypneic with a respiratory rate of 40, and he has decreased air entry over the right intramammary area. When you have decreased air entry, the most likely diagnosis here is a pneumonia. You don't need an X-ray to diagnose pneumonia. A clinical diagnosis is good enough. And you need to differentiate it from viral. But if you have a coryza, more cough, pneumonias don't cough initially. But if you have more cough, more wheeze, rhinorrhea, bilateral signs, this is not likely to be bacterial, it's likely to be viral. But if you have a sick child with localized signs, with bronchial breathing, toxic, this is a bacterial pneumonia. You need to choose antibiotics based on severity, based on age, because microbiological diagnosis for pneumonia is not easy. Now with the advent of PCRs, you have some headway, but there also you need to clinically correlate what report you get, because it can still pick up a commensal. The PCR can equally pick up a commensal. So blood cultures have yield as low as 13%. Sputum cultures may pick up commensals, and invasive procedures like bowel or lung biopsy are rarely done unless the patient is very critical. So empirical antibiotics are started to prevent mortality, and it's based on age, specific pathogens, and the presentation of the child. So these are the standard guidelines how you would treat a pneumonia. Neonates, you would use 2 antibiotics, cephalosporin with aminoglycosides. If you have a child between 1 to 3 months, the typical pathogens are RSV, Streptococcus pneumoniae, H influenza, chlamydia. So again here the drug of choice becomes penicillins or cephalosporins. In a child from 4 months to 5 years, RSV is, as I mentioned earlier, more and more viruses are now implicated for pneumonias. But you have other bugs like Streptococcus pneumoniae, H influenza, Mycoplasma, and group group A Streptococci. So here the drug of choice is penicillin or cephalosporins. In a child above 5 years, you have all these bugs, and including Mycoplasma becomes important. After COVID, we are seeing Mycoplasma infections in younger and younger kids. You must also keep staph as one of the differentials when you have children in older kids. So based on the etiology, one would decide what antibiotics. So if staph is suspected, you may have to think of MSSA versus MRSA. If it's MRSA, then vancomycin becomes the drug of choice. If it's MSSA, one can use cloxacillin, gormoxiclav, etc. But for the other bugs, you need to use either cephalosporins with and without macrolides. So this is for outpatient, as I just mentioned earlier, and this is a standard protocol which we use for inpatients, because inpatients are more sicker, they require parenteral antibiotics. Based on the pathogens, as I mentioned earlier, one can decide the antibiotics. So I'd like to conclude by saying that most RTIs in children are viral. Antibiotics treat bacteria, not viruses. So the first decision is, does this child actually need an antibiotic? Antibiotic stewardship, the right drug for the right bug, for the right duration and the right route. Overuse drives resistance, so watchful waiting is a valid clinical choice. So this is a summary of when you should use antibiotics. You can take a photograph and it will probably help you decide when you need to give antibiotics. Thank you so much. Any questions in the chat box? I don't see any questions.
No, ma'am.
Yeah, there are no questions. I will hand over the platform to Dr. Tanvi, who's my second year pulmonary fellow here at the SRCC Children's Hospital, who will take over the next lecture. Over to you, Tanvi.
Good afternoon, everyone. I'm Dr. Tanvi Modi, second year fellow in Pediatric Pulmonology at Narayana Health SRCC Children's Hospital, Mumbai. And my talk on inhaled drug delivery devices in pediatrics has been guided by Dr. Indu Khosla, ma'am. Now that we know about interesting cases, how to approach cases, the antibiotics and infections that we see, we are moving on to the next most commonly encountered problem in pediatric practice, the most commonly encountered confusion in pediatric practice about inhaled drug delivery devices. So let's move on to one case. A 1-year-old boy has a cold since 2 days, fever since 2 days, mild 100, intermittent, has a cough since 1 day. Mother has given salbutamol and budesonide nebulization at home twice yesterday because she remembered she had given it in the past and he had gotten better. Next day, she comes to you in the OPD and says the cough is not better despite nebulization. And this is the third time in the last 2 months he has had this episode, which is believable because of the AQI that we've had. And on examination, when you see the child, he's active, playful, vitally stable, no tachypnea, maintaining saturation, but has a bilateral mild wheeze and auscultation. At this point, if this is a child who has had recurrent episodes, mostly a parent would run to nebulize. A physician would think about whether you need to start preventive inhalers. And at this point, we are faced with a dilemma about what to do. So now, when do we need to consider inhaled medications? Obstructive airway diseases like asthma, bronchiectasis, CRU, post-extubation when we have airway edema, chronic lung diseases like BPD, cystic fibrosis, tracheitis, infections. They're approved for asthma, and I quote GINA 2025, where they have listed down the inhaled steroids that can be given below 5 years and above 6 years and above 6 years in adolescents and adults. All ages can be given salbutamol, levosalbutamol, LABAs, LAMAs, and there are combinations also available in the market. What we're going to do this time, rather than look into individual medications, we're going to talk about which device to use. So everything that we can see in brackets, the PMDI, standard particle HFA, then DPI, extra fine particles. We're going to see what these actually mean and how they should guide your treatment strategy for a patient. The other indications which are also now used and there are lots under research are hypertonic saline, Donase alpha for cystic fibrosis, adreneb as we already spoke about, inhaled antibiotics which are also widely used now. So what would you choose? We have MDI, DPI, nebulizers, spacers, smart inhalers, different types of nebulizers. There is a whole menu card of devices now. Parents are confused. Doctors need to appease parents, also need to keep the child's best interests in mind. And the parents getting anxious day by day really does not help. So, by the end of this, we aim to learn what exactly are these inhaled medications, the types and the mechanism of different devices, the pros and cons of each device, which will help you choose the correct device for your patient. So, first, I would like to say that inhalation therapy is not new. It's been going on since time immemorial, from 1554 BC onwards, where henbane was a plant which was smoked, which had anticholinergic properties, which was used as a treatment for a chronic cough. Then it's been described in the canon of medicine in China, it's been described in the Charak Samhita, it's been described by Hippocrates in Greece. It has come through the ages, even used as cannabis for sedation, atropa in datura for asthma, inhalation of arsenic for respiratory conditions, and they believed it used to be medicated vapors. In 1778, the term inhaler was first coined by John Mudge, and this is what he described. If you can see the image, the patient inhaled vapors through this mouthpiece, and there was bubbling through the liquid, which then generated the vapors which the patient inhaled. In 1852, the first dry powdered inhaler was made. In 1889, something called the carbolic smoke ball was invented, which has now been adapted to form the rotahaler. Riker, currently 3M, was the first brand that made the MDI that we know today. And it's only after the 1970s that holding chambers or spacers were invented and found to increase the drug delivery. So we're not dealing with anything new here, but now we do need to understand which one to apply when. So, what exactly are these medicated vapors that have these magic effects? They're nothing but aerosols. Aerosols are a suspension of either a solid or a liquid particle in a gaseous phase. And this gas that is used could be compressed air, it could be oxygen, it could be a propellant like hydrofluoroalkanes, it could be the patient's own inspiratory airflow, which causes the compressed airflow. The therapeutic agent could be either a solid like the powders, or it could be liquid like a solution or suspensions. Solutions are nothing but homogeneous liquids, whereas suspensions are inhomogeneous, and the solubility of the drug in that liquid affects the drug delivery. The drug delivery or the drug deposition in the lung depends on a lot of factors when you're giving any sort of inhaled drug device. The first is the device factors, then the patient factors, and the drug itself. The device factors, like we have the pressurized MDI, the dry powdered inhaler, small volume nebulizers, which we use in day to day practice. There are also large volume nebulizers which are used in ICU, which I won't be getting into today. And most importantly, is the interface that these devices are being used with to deliver the medicine to the patient. Now, the patient factors are the age, the understanding, the cognition, the anatomy of the pediatric age group, which is different from adults, the disease states like asthma, cystic fibrosis, the correct technique, the adherence, and the cooperation. And lastly, the drug factors itself. The size of the particles generated, the velocity of the particles generated, and the particle velocity and size determine how much they will be delivered into the airways because of certain principles of physics like inertial impaction, gravitational sedimentation, and diffusion. And as I said earlier, solubility and the dose that is delivered. We'll go through these quickly one by one, and then we'll deal with the advantages and disadvantages of each type. So the properties of the aerosol itself. These are a lot of words that we saw when we're dealing with, or if you read the label of on the nebulization machine or on the inhaler, then we will see a lot of these. So the dose is nothing but the active principle. We'll come to the fine particle fraction, which is a percentage of particles which are less than 5 microns in diameter from the aerosol. And we've got 5 microns because only particles between 1 to 5, ideally 3 to 5, have the best delivery into peripheral airways. Then we have the mass median aerodynamic diameter, which is how we judge the efficacy of any aerosol. And we have the standard deviation,
अर्ली ऐसा होप के अच्छा आएगा
which basically divides into whether they are a homogeneous dispersion of particles or heterogeneous. Why is this important? The equivalent diameter decides which part of the airway that particular medicine is going to reach. So here we see the upper airways. A large particle, which is more than 5 microns, will have a greater inertial impaction, which means that they are more likely to strike the posterior pharyngeal wall, get deposited in the oropharynx. In the trachea, they're more likely to strike the carina and get deposited at carina or branching sites, and they are less likely to reach the terminal airways. 2 to 5 microns are the ones that go by sedimentation, by gravitational sedimentation. They are small enough to reach the peripheral airways, because they are able to pass there, and they're also aided by gravitation. And the smallest particles that absolutely reach the alveoli are less than 2 microns, which can reach the alveoli by something called Brownian motion or Brownian diffusion. And these are the ones that are most efficacious. If I was to put this simply or just compare this to regular particles in our environment, we see that diffusion is the smallest one, so 0.05 to 0.5 microns, which reach the tracheobronchial tree. So in our environment, smog, automobile exhaust particles, tobacco smoke, viruses, and certain fumes. The ones that are aided by gravitation are the mid-range particles like 0.5 to 5 microns. So bacteria, dust, again exhaust particles, tobacco smoke. And the large particles are the ones that irritate our upper airways. This is an overview and it may vary from individual pathogens, of course. But fog, pollen, spores, dust, all of these tend to deposit in the upper airway. Another thing is any drug which is delivered at a high velocity is likely to strike the posterior pharyngeal wall and have a higher oropharyngeal deposition. Whereas the particles that are settling with sedimentation or which are reaching the alveolar by diffusion are likely to be smaller particles and they are moving at a slower velocity. These are some key concepts about the drug or the medications that you are choosing and the device you are choosing to keep in mind when you're prescribing an inhaled drug device. So now coming to the devices. How do you choose? The first is a soft mist inhaler. So we have the inhalers, we have the nebulizers. The soft mist inhaler is actually not available widely across the world and currently is in Germany only. It's not available in India yet. But the soft mist inhaler is so far has the highest drug deposition to the lungs in many studies reported worldwide because it delivers the smallest size particles at the slowest velocity. Next to it is the pressurized metered dose inhaler. These metered dose inhalers deliver them independent of the patient's effort, but they require coordination. So there is a jet of air that come. Many of them are polyspheric, so the size of the particles might vary, and they come out at a high velocity, which is why we use them with a valved holding chamber or a spacer, as we'll see later, which slows it down. The dry powdered inhaler. Now it requires patient effort because the flow, it is a solid particle and a patient's inspiratory flow is going to be the driving force to aerosolize the drug inside. So it delivers a high velocity. If it's not taken correctly, it has a poor drug delivery, but if it is taken correctly, it has a good drug delivery. And the final one and the most common household name is the nebulizer. Nebulizer is given in high velocities. There are a lot of options of nebulizers in the market. It is a parent's favorite equipment right now, and they deliver either suspensions or solutions, and they don't need patient cooperation. These are a broad overview. And now the final is we're going to go to the patient factors. As I said, the age and the anatomy of the respiratory tract are important determinants of how much drug is actually reaching the lungs. The age children have a higher larynx, epiglottis is higher, they have more collapsible posterior pharyngeal wall and supraglottic tissues, relatively larger tongue, they have faster respiratory rates, lower tidal volumes, and shorter inspiratory times. All of these significantly affect how much of the drug they inspire, how much gets deposited in the upper airways, and how much gets wasted to the environment. Younger children are not able to cooperate and they need different interfaces with masks, whereas older children may be able to cooperate, and adolescents and young adults can have synchronized breath actuated inhalers or nebulizers. So the cooperation remains an important point. And disease states, mucociliary disorders where there is thick mucus lining the airways, that's going to affect the drug deposition. asthma, and in adults there's COPD, where there's significant narrowing of the airways, which is going to affect the amount of drug reaching those narrowed peripheral airways. This is a study done which showed the left side picture shows the drug delivery in a healthy adult, of course, this is not a pediatric case, whereas the right side is showing the drug delivery in an asthmatic patient. You can see that there's impaired drug delivery. A lot of them are in the larger airways, and there's barely any going towards the periphery. So, why the inhaled route? Now that we've understood what and whom to give it, why should we give the inhaled route? First of all, it has a rapid onset of action. There's decreased systemic absorption, and there's better absorption of some drugs like tobramycin, which are not readily absorbed by the enteral route. They may not have the best oral bioavailability, but they have good inhaled bioavailability. And there's a better therapeutic index, which means that they will have a good effect at much less the required dose. So when we just go through the image again, when we give it, a lot of it is swallowed, goes into absorption, there's first pass metabolism which is bypassed. These are how it affects in illnesses and mucociliary disorders. So the advantages as I go on is there is a reduced frequency and severity of side effects because it is a direct delivery. There's a lower dose required for equivalent action. And disadvantages, however, may be that these devices may be bulky. They need repeated reinforcement of training. They need a proper technique. There is some literature, as I showed you, there's impaired drug delivery to diseased regions. And there are lots of variables affecting the drug efficacy, like the technique, device, and the dose. So, what is an ideal aerosol device? One, it must deliver an adequate dose. It should minimize oropharyngeal deposition. It should minimize systemic side effects. It should match the needs of the patient and should be acceptable to the patient. And it should be cost effective. So, now which device should we choose? We have pressurized MDIs, we have dry powdered inhalers, we have a soft mist inhaler, and we have nebulizers. Let's run through them quickly. The pressurized MDI, which is a very commonly used device, it uses a propellant called a hydrofluoroalkane, which is a high pressure gas kept under high pressure. And when you actuate it, the gas pushes the liquid is dissolved in that, and it gets atomized into small particles in the average microns of diameter. Between 3 to 5 is ideal and comes out as a high velocity spray. This has, it comes out at a very high velocity. Earlier used to be used with CFCs. They had a very cold jet spray and now replaced with hydrofluoroalkanes. There are newer techniques, newer inhalers called breath actuated MDIs, where the child can inhale and a strong inspiratory flow can trigger an actuation, and that itself acts like the air or the compressed air to drive the aerosolization. But a major problem with this is it needs to be taken with a spacer or a face mask, a spacer with or without a face mask. The technique needs to be taught to the parent or the child, reinforced at each visit, and is never to be taken directly due to a high oropharyngeal deposition. It's always to be taken with a valved holding chamber or a spacer. Now, why spacer? Because it reduces the delivery and the image can show you how. When the jet comes out, the larger drug particles and smaller drug particles are released into the spacer. The larger drug particles have by inertial impaction, they can settle over there, whereas the smaller drug particles are the ones that are actually inhaled. An ideal spacer is between 100 to 700 ml volume and a length of about 10 to 13 centimeters. Infants and younger children can require anywhere between 3 to 6 tidal breaths to ensure complete emptying of the chamber. Children are encouraged to take tidal breaths, and older children can take deep breaths because that achieves the required velocity, and the smaller drug particles can further move by diffusion into the alveoli. A child taking more than the required number of breaths has not shown to have any improved drug delivery. 5 to 6 tidal breaths are optimum. Now, 0 to 3 years the metered dose inhaler, the child will not be able to take the MDI with only the spacer and the mouthpiece. So they are recommended to use it with a face mask. Above 4 years, children can use it directly with the mouthpiece. Now, how to give this MDI? This is the reference here is Kendrick's Disorders of Respiratory Text, but you can get this in any reference on the internet, Google. Even a parent can be given a handout to reinforce the technique and check it at every visit to make sure they're doing it properly. Pressurized MDIs should never be taken directly. The way to give it is it has to be shaken before giving each puff. The inhaler is then attached to the spacer. The mask or the mouthpiece is placed into the mouth. If the child is using a mask, it has to fit tightly, creating a seal over the nose and mouth, making sure there's no gap, making sure there's no leak, and actuate the MDI. Let the child breathe in. Based on the size of the spacer and the age of the child, the number of breaths can vary, and that needs to be checked with individual devices. And if there are two breaths or two actuations required, there has to be a minimum gap of 30 seconds between the two actuations. Two actuations should not be given back to back into that same spacer. This is very important to teach the technique to the parents and the way to wash the spacer. The delivery of drug is also affected by the charge on the plastic. You get hypostatic spacers, plastic spacers. There are some metallic spacers also in the market, not widely available. So when you're washing these spacers, they can be washed in a little bit of soap water or detergent water and left to air dry or drip dry. They should not be washed in regular tap water. They should not be rubbed because that affects the electrostatic charge. And further, more particles could get delivered on the spacer walls, leading to lesser of a drug delivery to the airways. If the child, here the image shows a child taking it herself, of course, but even if a child is taking it herself, has to be supervised and reinforced by a parent or guardian. So the advantage of the MDI is a rapid onset of action, again a lower dose for an equivalent action, and because the dose is in micrograms, it's a reduced frequency and severity of side effects. However, disadvantages that we have seen with parents and children is the spacers are bulky, they're embarrassed to use them in school, the masks are especially bulky, they need repeated training, they need repeated cleaning, and sometimes the child is irritable, not taking it properly, moving a lot. Parents are in a rush, getting late for school. So, all of these variables affect the drug efficacy. If it is taken properly with all appropriate requirements met, a pressurized MDI can have anywhere between 40 to 50% delivery in the drug in the lungs based on certain studies that are done, which is if there is no leak from anywhere and taken optimally at each visit. If there is any leak, then the drug delivery can fall to as low as 8%. Moving to the next one. The next is a dry powdered inhaler. The dry powdered inhaler, at least in other parts of the world, has so many different types as we can see. There are single dose devices, there are multiple dose devices where we can load pellets and it keeps dispensing the doses. What we also have a dry powdered inhaler in our country, which is widely used. There are small drug particles which are usually mixed with carriers like lactose or glucose, which are to be inserted. The drug is to be inhaled over a punctured drug containing capsule, but it needs a high inspiratory flow rate of at least 20 and some studies say 30 liters per minute. This kind of an inspiratory flow rate cannot be achieved by younger children. So DPIs are usually used only for older children, maybe adolescents and above. The prerequisite for appropriate drug delivery through a DPI is the inspiratory flow rate and the technique. If it is not proper, then there's a higher oropharyngeal deposition and it is not as effective as a pressurized MDI. So here, while the advantages stay a lot, this is more compact because it doesn't need a spacer. It does not need a propellant, so it's believed to be more environment friendly. But I already highlighted the disadvantages and it needs repeated training and proper technique. Coming to the last and our parental favorite, the nebulizer. There are queries that we get very often that I'm traveling, I can't carry this big nebulizer with me, so I have a handheld nebulizer. Can I carry that instead? And here we think that, okay, now I have to explain everything to the parent, and we have to deep dive into the different types of nebulizers, which can be used, which can't be used, and when, the indications of each, and the maintenance of each. The first one is the jet nebulizer. The jet nebulizer is available in every clinic, every household as an emergency. Even what our case right in the beginning, the mother immediately rushed to give the nebulization, which is nothing but a jet nebulizer. In this, it requires an electrical point. Electricity driven compressor compresses either air or in a hospital oxygen to push it through a nozzle at a minimum flow of at least 6 to 8 liters per minute, and that's what aerosolizes the drug. It's good in case of emergencies. It is good when we need continuous nebulizations. It is good if a child is uncooperative, if they're not keeping the spacer and the mask. It is good in case of severe respiratory distress. It is extremely common, easily available, and currently most cost effective also. The next one is a mesh nebulizer. The mesh nebulizer is the handheld portable device that is available in the market now, which most people like to carry in their bags. But the mesh nebulizer is silent, it is battery operated, it is portable, it is more expensive, and it is high maintenance. Why is it high maintenance? Because there's a vibrating or a fixed membrane with piezoelectric elements which vibrate to push the drug through that mesh to deliver it to the patient. The disadvantage of this is that there is mesh clogging, it requires periodic cleaning, it requires periodic maintenance. The last one is an ultrasonic nebulizer, which has again high frequency vibrating crystals, but this time they are directly converting the fluid into aerosols. So it's useful for larger volumes of medication, but it generates a lot of heat and it cannot be used for inhaled steroids, antibiotics, Donase alpha, because these tend to get denatured and we cannot use this on daily basis. There are also larger particles which are delivered and they have another variable drug delivery. So if we summarize the machines and how they are used, the first one is the jet nebulizer. The second one is the ultrasonic one where the piezoelectric energy pushes it through a perforated membrane which aerosolizes it. Whereas the middle one is the ultrasonic neb, which is directly the piezoelectric crystals are converting into aerosolization. Wherever the piezoelectric comes, there is certain heat generation, and these cannot be used for inhaled steroids. We have a sum up of this. So the disadvantages of the jet nebulizer is it requires a source of energy, it is bulky, and it has a lower efficiency. The mesh is more expensive, requires regular maintenance and cleaning, disassembling it and cleaning the mesh. And the ultrasonic one cannot be used for inhaled steroids, causes high large particles, and has heat generation. We've highlighted this. Additional disadvantages of nebulizations is that they use a very high dose. They have to account for the dead space volume which is remaining in the nebulization chamber. So for every 5 ml that you are using, there is about 1.5 ml which is getting wasted. There is about 40% also which is getting lost to the environment if the interface is not proper. If the mask is too tight or is fixed on the face, there is some amount of deposition on the skin. There is a large amount deposited in the oropharynx. There is a lot of drug which is wasted. So the total drug driven, only about 40% is effectively delivered, of which only 10% is actually reaching the lung. Another thing is there's a high contamination risk because of the humid environment kept. So these inhalers, these nebulizers kept at home have a risk of contamination, need periodic cleaning, they need disinfection, and they ideally should not be used as your first stop shop at home. However, when you come to the ER, if a child is extremely irritable, not taking the inhaler, because it can provide continuous nebulization, continuous aerosolization, the nebulizer is preferred. Now, so which device to choose now that you know everything about all the devices? It has to be based on the patient age and cooperation. It has to be based on the availability. It has to depend on the cost and the affordability of the patient and the medication required. So the MDI with a spacer, the drug deposited in the airway is 10 to 20%. This is on an average. Plain MDI is 5 to 10%, a DPI is 5 to 10%, nebulizer is only 1 to 5%, and nebulizer has significantly higher oropharyngeal deposition. We have a comparison again, which I'm not going to go through, it will be a repetition. Now, the do's and don'ts. We have parents who are not going to listen to us, they are going to carry the nebulizers. So, what are the do's and don'ts that you have to tell them in case of an emergency? First is they have to use the correct dose, they have to use the dilution specified to them. We as physicians have to tell them the dilution and how much of the rescue they have to use. They have to ensure a tight mask or seal or a mouthpiece above the age of 5 years, which will improve the medication delivery. The child has to be calm because a crying child, a shouting child is not going to be able to take any inhaled medication properly. The child should be kept upright. The nebulizer has to be clean and dry before every single use. Oxygen driven nebulization is the ideal way to give it in a hospital setting. And most importantly, one medication at a time. The diluent has to be either normal saline. Changing the diluent, mixing medications is going to affect the size of the particles which are dispensed. So it is not going to have an optimum effect. Larger particles, smaller particles, the more the disparity between the particle sizes, the lesser effect it's going to have. So don't use nebulization for mild disease. For mild disease, a pressurized MDI with a spacer or a mouthpiece will be most efficient. Don't nebulize the crying child. Don't use incorrect dilution. Don't mix. Don't neglect the cleaning. Don't assume that a nebulizer is stronger or better than an inhaler, and ensure a good fit. We're going into the future, and as I was preparing for this and looking at what options are coming up, there are a lot of smart devices coming into the market or under research. There are smart inhalers, breath actuated nebulizers, smart inhalers which give feedback on technique. They give early warnings and exacerbation, patient education, assessment of response, and monitoring for the doctor. These are all in the pipeline, and we hope to see this in the upcoming AI driven generation. So, my take home message for today is for effective inhaled therapy, right drug, right device, right technique, and that will lead to success. I'm handing over now to my colleague, Dr. Geetesh, Pediatric Pulmonology Fellow First Year, who is going to deal with common misconceptions and malpractice and debunk a lot of myths in pediatric pulmonology practice. With that, I thank you all and I invite any questions or comments, if any.
Yeah.
There are there are no questions. Thank you everyone for listening. I invite Dr. Geetesh to please take over.
everyone. I'm Dr. Geetesh. Good afternoon, everyone. I'm Dr. Geetesh Baijal, Pediatric Pulmonology Fellow at NHSRCC Children's Hospital. My topic for discussion today is breathing easy, debunking myths, and finding solutions. So, as in the previous lecture, we have covered how to use inhaled drug delivery devices and the appropriate drug delivery devices. Okay, so I'll run you through common case scenarios which we commonly encounter in our OPDs. So, scope of my presentation is to address the myths related to respiratory symptoms, discuss on the evidence-based practice, and provide culturally sensitive solutions. So, this is the first case. He's a 7-year-old male child who presented with complaints of recurrent cough and cold associated with nocturnal awakening and breathlessness every month. The frequency of the episodes have increased since the past 6 months. The child received nebulizations with bronchodilator and steroids each time for a period of 5 days, and one course was given every month. Should nebulization be continued in such a scenario, or should management be changed? What is your take on this? Or does anybody have any takes on the management? Okay. So, proceeding with, we advise to start MDI inhalers, which is the appropriate inhaled drug delivery device to be used in this setting. The parents, however, they were not convinced because they believed the nebulizers are more safe, more effective. The parents were told that the inhalers are meant only for adults and are harmful for children. So there are many like advertisements everywhere. The subjects which are used, they are always adults. Nobody has ever seen a child being as a subject on whom inhalers are being like taught. So what you see is what you believe. So the parents also believed that inhalers are meant only for the adult, and they also felt that the inhalers are addictive. So they did not start the inhalers. Now, this is the first myth which we'll address, which that is the nebulizers are safer than inhalers. So now, advantage of an MDI inhaler, as discussed previously, the MDI inhaler, it has a targeted delivery of the drug to the lungs. The lungs is the site of action where we want it in the smaller airways, and the MDI inhaler serves the same purpose. Also, if you compare a nebulizer with an inhaler, there's a lesser dosage requirement of an inhaler. The dosage requirement of a nebulization is in milligrams, whereas in an inhaler, it's in micrograms. So there's a multifold increase of the dosage required for a nebulizer. Also, there's always an infection risk with nebulizers. No matter how properly you clean it, the droplets which are remaining, they act as a source of harboring the bacteria. Okay, so that is not advisable. The second myth, which is that the nebulizers are more effective than inhalers, which is also not true. There are many studies which claim for the drug delivery efficiency, the LDMA spacer has 10 to 40% delivery to the lungs, whereas for nebulizers, it is only 5 to 10% delivery to lungs. The rest of the particles they stay in the larger airways only. Also, the onset of action, if you compare, MDI acts in minutes, whereas nebulizers takes 10 to 15 minutes to act. So if you want a rapid action, it's an MDI inhaler which you should opt for. So these are few studies, both in adults and pediatric population, which show that an MDI inhaler is more superior compared to a nebulizer. So the third myth which the parents had that the inhalers are addictive. Now, why do they feel so? because what happens is when the child uses inhaler, it has a rapid onset of action. Also, the child shows improvement. Now, when the child stops the inhaler, the symptoms return. So now parents feel that the child has become now dependent on inhalers, that he will not overcome it. But that is not the does not cause eye addiction. I However, the parents were reluctant, and the parents read about steroids on Google and they stopped inhalers after 1 week because the grandmother said steroids are bad for health and they affect growth. After 10 days, the same child presented with an acute wheezing episode and required PICU admission. He required O2 support, IV steroids, and bronchodilator nebulizations. So this is the myth that steroids are dangerous for children. Is that so? No. So advantage of using inhaled corticosteroids are that they targets the underlying chronic inflammation. It reduces the frequency of episodes and prevents exacerbation. It improves the lung function. It prevents airway remodeling, and the dosage is in micrograms, which does not affect the child's growth. So you can explain to the parents that it the action is only in the lungs where we want it to act. There is minimal systemic absorption, and so it will not cause any systemic side effects. They should not have the steroid phobia, which we call. So, so this same patient had recurrent cold and cough. Grandmother advised. So she started with the dietary restrictions first, like stopping banana, milk products, ice creams, citrus fruits. Then child did not benefit. She stopped the child's air conditioner as well. Now, after doing all this, still the child had persistent symptoms, taken to a local doctor, and was started on antibiotics. And the child showed improvement. Now, the grandmother was very happy that the child has shown improvement. The same child presented again after 1 month, and another local doctor was consulted. Only symptomatic management was given, no antibiotics were given. Parents were reassured that of the benign self-limiting condition of viral etiology. However, the grandmother was not happy. She was like कि doctor ने strong medicine नहीं दिया. The previous doctor who had given antibiotics, she was very happy with the treatment. The grandmother insisted on antibiotics for cough to the doctor, but the doctor did not prescribe antibiotic. What should have been ideally done in this case now? Anyone? Also frequently encountered in your OPD, rarely a cause of food allergies. Symptoms of allergy, they need to be correlated with the timing of food intake. Okay, so there are early phase reactions and there are delayed phase reactions. Also, sensitization can be demonstrated by skin prick tests and component resolved diagnostics. However, results need to be correlated clinically to find a clinical correlation. Now, a mere sensitization does not indicate allergy. It has to be correlated with clinical symptoms. A skin prick test only gives you sensitization, whether the child is sensitized. That's it. So you have to correlate clinically, and then you make a further plan of management. There's a new modality which is component resolved diagnostics, which tests for serum specific IgE to the allergen, but that also requires clinical correlation as well. So this myth which the grandmother had that all coughs require antibiotics or a very strong medicine. Why does this exist? Because they have these expectations कि doctor ने strong medicine नहीं दिया, previous experience of recovery after antibiotics. So now they trust the previous doctor more than you. Also, there is easy availability of antibiotics over the counter. There is no requirement of prescription. The most common causes of cough have to be explained to them, which are of viral origin and upper airway cough syndrome. So this is a frequently misdiagnosed upper airway cough syndrome. So if you should always ask whether the child has any congested nose and then correlate the timing of the cough with his sleeping pattern and the time when he is having aggravation of the cough. So such upper airway cough syndrome does not require antibiotics. It requires only antihistaminics. Now, the detrimental effects of giving antibiotics also have to be explained to the parent that it creates unnecessary antibiotic resistance. There's unnecessary side effects of antibiotics like diarrhea, vomiting. There's also microbiome disruption. Also, we have to see when we should suspect bacterial infection. Now, we have to see red flag signs, which are pointers towards bacterial infection, like high grade fever, fever lasting for more than 3 to 5 days, and of high grade tachypnea, chest indrawing, toxic appearance, hypoxia, refusal to feed. These all are red flag signs, and they warrant starting antibiotics. A healthy child develops upper respiratory tract infections 6 to 8 times per year. That is, every 2 to 3 months he will have. That is absolutely normal. And that does not mean the child is immunodeficient or requires antibiotics. Nothing. And not every cough requires time. Most just need time. Mostly, not every cough needs an antibiotic. Most just need time, care, and reassurance. Now, so we have another case. So there's a 1 month male infant child who developed cold and cough. The grandmother, as home remedy, instilled oil in the nose to clear secretions and prevent infection. And this was done whenever the child used to develop cold. The grandmother felt that on instilling oil, that would prevent the entry of the virus and would prevent further infection and would restrict the infection which the child is currently having. The gradually child over a period of months developed persistent cough with fast breathing. This is the CT of the child. They had presented with a CT scan. This is suggestive of lipoid pneumonia. This was all because of exogenous oil installation in the nose, which caused damaging of the lung parenchyma. So this myth is oil installation in the nose improves breathing. It is very widely practiced in rural and urban households. It is often done before sleep, which further increases aspiration risk. It is rarely disclosed unless specifically asked. So in our history taking, it is necessary to ask such points. Otherwise, you'll miss the diagnosis. The alternatives which can be advised instead of an oil installation, a normal saline drops and ensuring adequate hydration. How to counsel parents in such a scenario? Now, you'll say, I understand this is the common practice, and oil in the nose may seem harmless, but it may quietly enter the lungs and cause serious damage. So, there's another myth that the child has allergy to dust. The parents were told that the child is allergic to dust. Is it a dust allergy? It is not dust allergy. It is actual dust. It is actual allergy to dust mites and not to the dust. So dust mites are an organism. They live and multiply in warm and humid places. They prefer temperatures at or above 70 degrees Fahrenheit with humidity of 70 to 80%. They thrive in well humid conditions. They found in pillows, mattresses, carpeting, and upholstered furniture. And they float in the air when anyone vacuums, walks on the carpets, or disturbs bedding. And they settle without any disturbance. So this is how a dust mite looks like. So in this case, what measures you'll ask them to take are dust mite avoidance measures. So what are those? You have to wash all the blankets, mattresses every week. Wash it in hot water and let them dry in sunlight. So the sunlight and the warm water, it destroys the dust mites. Another simple technique is you can ask them to just iron the mattress and the this pillow covers just before sleeping. So what happens is the dust mite lays their excreta, and the excreta is what is inhaled by the child, and the child becomes allergic to the dust mite excreta actually. A child typically spends most of his time at one place while sleeping. That is 6 to 8 hours of sleep minimum. These dust mites, they also tend to come out at night. They roam around the child, they deposit their excreta, and that excreta is inhaled by the child, and the child develops symptoms. The symptoms are often more early morning, presents as frequent sneezing, multiple episodes of sneezing, um, nasal itching, watering of eyes, this all will be there. All the allergic manifestations will be there. So, it is very pertinent to tell them that the actual allergies of dust mites. So, that was my case. Thank you so much. I invite any questions if anybody has any. Thank
Thank you everyone for your active participation. Thank you.